everyone, I'm Dr. Chakladar. I'm a gastroenterologist in Toronto, and I'm the chair of the medical operations of Humanity Auxilium. I would like to welcome and thank you all for joining us today for this discussion of this eminently important topic of reopening of schools during COVID-19 pandemic. Humanity Auxilium is a Canadian as well as US-based NGO that was founded by Dr. Fauzia Alvi. Dr. Alvi is a family physician based out of Calgary. Our goal is to not only help in the short term, but also in the long term in terms of meeting medical needs of low resource communities locally as well as internationally. We are dedicated to strengthen these communities and also to make them self-sufficient. I would also like to thank Getz Pharma for this distinguished opportunity. Our physician volunteers have been going on medical missions, not only to help these communities by treating their patients, but also to teach the frontline care workers to help these communities better. However, due to the COVID pandemic, our physicians have not been able to travel abroad, but this has not dimmed our desire to help these frontline care workers. We have been doing virtual sessions since April of 2020. The idea is not only to equip these frontline care workers with the latest and up-to-date information about COVID, but also to let them know that they have not been forgotten in the eye of the pandemic. Education is another pillar of Humanity Auxilium. Access to education is the basic right of every human being. Today's webinar is a marriage of education and health, and we can see how in this day and age they're so intertwined. Our expert panelists will help shed light and navigate these uncharted territories, and also in the long run we will be able to open schools and keep our children safe, as well as help them to learn, grow, and flourish. Without further ado, let's get started with our webinar today. I would like to introduce our first speaker, Dr. Mehreen Arshad. She's an assistant professor at the Northwestern Feinberg School of Medicine and also a pediatric infectious diseases specialist at the Lurie Children's Hospital of Chicago. Welcome, Dr. Arshad.
Thank you. All right, so thank you everyone for being here. I think this is such an important topic. I'm really excited to talk a little bit about this and share some of the recent data that may be of help to everyone who is sort of thinking about sending the children to school and thinking about helping those who are running schools in different parts of the world. So my specific topic is school opening and the potential for SARS-CoV-2 transmission by children. So in the recent past, you may have seen there's just been a lot of news about schools opening, but then having to close down because a number of people have been positive, including both students and staff. There was this viral picture that had that from a high school in Georgia that looked at showed packed school corridors without anyone masking, and of course after this the entire school district had to shut down for a little while. More recently there was some news that more than 9,000 children had in Florida in the US were confirmed positive for COVID-19 within the first 15 days of school reopening. So this sort of brings us some important questions regarding the facts that we have to work with. So some of the facts that we have to work with when we think about school opening are the following. COVID-19 is here for a while. We all know this, that there doesn't seem to be a clear end to this pandemic. We're not exactly sure when the vaccine will be available, and we're not exactly sure how the seasonality of this virus will affect us in the future. Schools, however, are essential for child health and well-being for a number of different reasons. We also know that schools that have opened without precautions have had high rates of failure, even when community transmissions have been low. Israel's experience is something that we've talked about in the past. Israel had very low community rates of COVID when they opened school, but soon after schools opened, their numbers started to go up, and they had to go down into a community-wide shut down again. So we have to figure out a way to open schools safe. So what do we know about COVID-19 in children? Most children are asymptomatic or have only mild disease. In the US, the rates of hospitalization for COVID-19 are about 8 per 100,000, and that compares to 164 per 100,000 for adults. So clearly children do not require hospitalization at the same rates as adults. However, when children are admitted into the hospital, 1 in 3 children have required ICU level care, meaning that children, though they don't require very high, though they don't often require hospitalizations, they do require higher levels of care compared to adults. Risk factors associated with severe disease are obesity, chronic lung disease, and prematurity, that is less than 37 weeks of gestation, in children that are younger than 2 years of age. There was also a recent British study that looked at data from 260 hospitals in the UK. 35% of those admitted were under the age of 12 months. So again, younger children are at higher risk for having more severe disease. Only 1% of their patients died. That is six out of the 627 patients that were admitted. And all of them had some profound comorbidity or the other. 11% of the patients who were admitted met criteria for WHO MIS-C, which is the multisystem inflammatory syndrome in children that is thought to be a post-COVID inflammatory condition. And this graph right here on the left-hand side of the screen basically just shows the common symptoms that these children will present with, and those include fever, cough, nausea, vomiting, some shortness of breath, fatigue. So not very different from adults, but also not very different from some of the other common viral illnesses that we see in children. So there are lots of unknowns regarding COVID-19 in children, and that are specific to school, to school opening. And these include questions like, do children transmit virus to adults or other children? We do have some data on this. However, and our initial experience showed that more than 90% of children who were COVID-19 positive also had a family member who was positive. But the caveat to all of this is that when these data were published, schools were among the first to close. And so this data is sort of in the environment when schools were closed. And so it's probably not very reliable indicator for when schools open. So will we see an increase in pediatric cases when schools open? I think we have been seeing, at least in the US, as schools open. I know that in many districts, the cases of COVID-19 have been going up in the younger age groups. What about an increased risk to teachers, parents, and other caregivers? And then the other question that comes up very often is, will a pediatric vaccine against COVID-19 be available anytime soon? I will not touch on this later in the presentation, so I'll just say that right now there are very limited studies going on in children, and so I do not think that a pediatric vaccine will be available anytime soon. All right, so what is the data that we have right now regarding transmission of the virus from children to other children or children to adults? So this is a study that was recently done in South Korea, and they showed that they basically showed that children who were the younger children are able to transmit to their household contacts. So this is basically looking at household contacts and the number of household contacts that were positive out of those that were traced. And you can see that in the 0 to 9 age group, 5.3% of their contacts were positive. But when you look at the 10 to 19 age group, that's about 18.6, and that's among the highest percent attack rate compared to all the other age groups as well. So clearly children that are 10 to 19 years of age have among the highest rates of transmission to the family. However, the study did not look at directionality of transmission, so we're not exactly sure who got transmitted first, but I think this was one of the first indications we had that at least this older child age group, the 10 to 19, may actually be fairly efficient in transmitting to their household contacts. There was another study. This was actually done from my institution that looked at the nasopharyngeal carriage of SARS-CoV-2 And they saw, they basically looked at 145 patients with mild to moderate illness within 1 week of symptom onset. These included children as well as some adults for comparison. And they observed that the differences in median CT values between young children and adults was approximately 10-fold to 100-fold greater in the younger children. And again, CT values are basically an indication. So low CT value is an indication of a higher viral load. And as you can see, children that were less than 5 years old had significantly higher viral loads compared to adults. Now, again, these are infected children that were in the hospital. Another study, this is just in the preprint domain right now, but it was done by a few colleagues of mine, so I know that there is some solid science behind it. This study looked at the transmission of the virus to other family members when they identified a positive child in their pediatric infectious disease clinic. And what they saw was that when they looked at the household members of a positive child, there was a much higher incidence of positivity among siblings compared to among parents. So siblings were much more likely to be positive of that index child compared to a parent being positive. The other interesting thing that came up was that asthma actually seemed to be somewhat of a protective effect in that children who had asthma or siblings who had asthma were less likely to be infected compared to those that did not. The study also looked at the viral load in the nasopharynx of the children and their contacts. And not surprisingly, they showed that the highest viral load is right before the symptom onset. And therefore symptom screening, so when we think about schooling and the procedures for safe school opening, symptom screening alone would not be very helpful and enabled in identifying infected patients, because as you can see, a lot of these patients have fairly high viral loads even before the onset of symptoms, and are therefore able to transmit the virus. A more recent study also looked at an overnight camp that was in the US again, and this was in Georgia, and they basically had very high numbers of infected patients, of infected children in their camp. So the study basically sort of did a deeper dive on what happened at this camp. So all the trainees, staff members, and campers in this particular camp were required to provide documentation of a negative viral SARS-CoV-2 less than 12 days before arriving. Staff members were also required to wear cloth masks, and if they actually did, we don't really know. But they were all tested negative 12 days before arriving, but there wasn't any specific instructions given to the families or to the campers on what to do within those 12 days. So many of them may have had a negative test 12 days before, but then got infected sometime right before coming into the camp. Some of the measures that were not implemented were that kids did not wear, or the campers, the children did not wear cloth masks, only the staff members did. The windows and doors were not opened to increase ventilation, and there were a variety of activities that were done indoors and outdoors that included vigorous singing and cheering. And so what they showed was that, again, similar to the other studies that I've quoted, the younger age group had a fairly high attack rate. And then they also looked at the attack rates compared when looking at the cabin size, so the number of children that were basically sleeping together in one cabin. So not surprisingly, the smaller cabins where they had 1 to 3 children per cabin had a lower attack rate compared to those where they had a large number of children sleeping together. Now, not everything is doom and gloom. There have been some success stories as well. So before, and this was a study that was this was similar overnight camp that was in Maine, and they did things a little bit differently. So before camp, staff and the campers were asked to quarantine with their family for 10 to 14 days before arrival, and they were all required to test negative for COVID-19 and be screened for symptoms. So they were not only tested, but there was also the organization also made sure that they were not getting infected between the test being negative and the time that these students and staffers came into the camp. During camp, staff and campers were tested again and quarantined together in smaller groups for first 2 weeks. So there was, they maintained their small cohorts. And so there wasn't a lot of cross-contamination, even when somebody did get sick. Campers were encouraged to bring their own sporting equipment, and everyone wore facial coverings and practiced social distancing when they were outside their own group, and among other measures as well. And they did have some cases. So there were 4 potentially infected campers and staff. However, there was only 3 cases within that actually turned out positive in this group after the camp started, compared to the dozens of cases that happened in the prior camp that I had talked about. And they did not have any additional infections during the 6 to 8 weeks of camp. So basically what that shows is that when you follow proper precautions, even though you may get some cases of COVID-19 in the school or within the camps, there are ways to mitigate the spread of that virus to other uninfected members of the same school or camp. So some of the take-home point from my part of the presentation is that children can get severely ill from COVID-19. Younger children may carry significantly higher viral loads than older children. The older children may actually be more efficient at transmission of the virus to other household members and to teachers as well, for example. Relying on symptom screening alone is likely not adequate. The risk of infection is higher when a sibling is infected compared to a parent. And overall, distance, masking, ventilation, reduced class sizes are absolutely essential if schools are to be open safely. All right, so that concludes my end of the presentation.
Thank you, Dr. Arshad. That was a great presentation. We will move on to our next speaker, and thank you for submitting questions. We will take the questions towards the end. So I will introduce my next speaker. Our next speaker is Dr. Samia Ahmed. She is a pediatric neurologist, and she's practicing at Children's Hospital at San Antonio, and she's an assistant professor of Baylor College of Medicine. Welcome, Dr. Ahmed.
Hello. Assalamu alaikum. Can you hear me?
We can hear you.
You can hear me? Okay, great. Excellent. Thank you. Assalamu alaikum, ladies and gentlemen. Thank you so much for the opportunity to speak to you today. My topic is how important is schooling for children? And I want to thank Humanity Auxilium and Getz Pharma for allowing me to speak on this topic. So in the next several minutes, we will understand the primary and secondary benefits of schooling. We will also appreciate the magnitude of school closures during the pandemic, and we will come to realize the short and long-term effects of school closures on children and their families. So just to briefly go over the history of schooling, this goes back to like about 2000 BC. In Middle Egypt Kingdom, they started having schools, and this was more related to religious teachings and restricted to more of the elite of the society. And then this sort of pattern continued into the 500s, 1500 AD, where again schools were with monasteries and cathedrals. It was not until about 1000 AD that the first school was established that was separate from a house of worship, and that was in Nizamiya, Iraq. By the 1800s, there was a mass movement towards universal education for all young children and young adults. And this was a politically driven movement, especially in Europe, because they wanted to promote orderly political behavior. And of course, now this is nothing like what the world has seen, how school disruption has occurred during the COVID-19 pandemic. So what are the benefits of schooling? I think the majority of us think about education, so knowledge, literacy, but also like productivity, but critical thinking and creativity. Also very important are the social and physical benefits of schooling, the friendship, the mentoring, the networking that children have. But also schools tend to be a place of safety and security. They have a sense of belonging and they learn leadership. Also, they become very physical in school. They are almost every school has a curriculum to have some exercise. They have team sports, and from this they learn skills and sportsmanship and teamwork. But then there are also some downstream secondary effects. Schooling has provided some of the largest network of childcare for families, both during school hours, but also there's before school hours care, there's also after school hours care. And this allows parents to work outside of the home, which in turn gives them further financial stability, empowerment. Children in many parts of the world also receive free meals or subsidized meals at school, such as in the US, every child has access to free schooling, they can have a free breakfast at school, and lunches can be subsidized as well. This all leads to better health, and because the children are in a safe environment, they are away from the risk for domestic abuse and violence. Especially children who are maybe hyperactive or disobedient, subordinate. This takes them to an environment which is very supervised, controlled. There is a hierarchy versus a home which may not have as much structure. When children remain in school, they stay out of crime and risky choices. The longer children stay in school decreases the chances of child marriage. And of course, once marriage is delayed to an appropriate age, this leads to decreased maternal deaths. So what happened? So in April of 2020, over 90% of enrolled learners, or 1.5 billion young people, were out of school. This is a map by the United Nations Education for Scientific and Cultural Organization, UNESCO. And this in April shows how almost most parts of the world were completely closed for schooling in COVID-19. The pink parts show that they were partially open. So what effects do prolonged school closures have? Well, we know that there is data to prove that there's loss of future opportunities, such as economic benefits and additional earnings. There are some estimates that suggest that each additional year of schooling equates to 10% additional future earnings. Some of the information we get is from past incidences in history where there was a disruption of schooling, such as in World War II. When they study the effects of this school closure, they noticed that even 40 years later, there have been economic impacts to the children who grew up and who had missed schooling. So what is happening currently? So from this study that looks at the social crisis that's happened, they come up with two very important points. One is that school closure is detrimental for social and health consequences, and this is especially so for children living in poverty. Again, because of this food insecurity that happens, but also we know quite well that there is a widening of a learning gap between children of lower socioeconomic background compared with higher socioeconomic background. So let's delve in a little bit further why this happens. So if we look at some of the data that we have already, we know of this phenomenon called summer reading loss. In this, we understand that during the usual summer vacation that happens, children regress in their reading skills. So in a first grade, if they have summer vacation for 2.5 to 3 months, they can lose 1 to 3 months of reading skills. And the same for second grade, and this adds up. But what we see is that children who have a very favored background, they don't have as much of a setback. But children who are more disadvantaged have a further setback in reading. And as we follow this through, if this happens every year for several years, by the time they reach the end of 5th grade, the socioeconomically disadvantaged children have lost up to 3 years of learning. There are some critics of this study in that they think that children are not doing anything during the summer, but this is a fairly well understood fact. Also, low-income children, why are they disproportionately affected? First of all, they may have decreased access to resources for distance learning. So they may not have good internet connection. They may not have the option for online learning. Their parents may not be available to help them troubleshoot technical errors, or their parents may just not even have the knowledge to teach them. They may have very low literacy themselves. They may have an unstable environment, poor access to electricity, maybe not even a quiet room where they can study. And again, their parents may not be able to supervise them because many of the families of lower income do not have the luxury of being able to work from home. People who work from home are generally white collar. They may have jobs in like the information technology sector, but many blue collar jobs such as bus driving, janitorial work, security, they all have to be done in person. So those parents are really not able to work from home. Now, even within this group of lower socioeconomic children, or even within young children, we realize the ones that are more affected are the younger children, because the foundations of literacy are taught in the earlier classes. So especially those first, second, third grade levels. So how have countries responded to school closures, and what forms of education have they tried to implement? Now, again, we see a large disparity. The higher income countries have done a lot of online only, with just a little bit of this, well, with some portion of this, television and radio. As we go down the spectrum, the lower income countries, there's very little online schooling. Now, if we go by regions of the world, we see here in South Asia, there is very, very limited access to online only. There may be a little bit, but not online only. And this curve shows us the average share of the population that has connection to the internet. So we are at about 30%. What about mental health and school closure? So those with mental illness, such as depression, report that 83% of them have a worsening of their condition since the pandemic started. Reports of increased stress, anxiety, domestic violence, alcohol, and substance abuse. Then children with developmental disabilities, this has caused them to have an inaccessibility to resources that are found at school. So the therapies they would get, the set routine they would have, peer support, life skills, access to special education teachers has been disrupted. One thing is that the preliminary findings suggest that there is no rise in suicide rates among children. And this is from only one study that I could find from Japan, from July of 2020. And what about the impact of school closures on healthcare providers? So this is very interesting. You have to, this study was very interesting in that they said you have to balance the benefits of school closure against the cost of healthcare workers who are not able to work because their children are at home. So the downstream effect of the healthcare provider not being able to work because of lack of childcare may cause some additional mortality to the public. So this needs to be very carefully balanced. So school closures alone, we know, decrease deaths by about 2 to 4%, which is actually marginal compared to other forms of social distancing. So policymakers do need to be aware of equivocal evidence when schools are being closed, and you may have to have combinations of distancing measures that need to be considered. So in conclusion, I'd like to say some important points. Schools have an overarching benefit on the educational, but also the social, the physical, and the mental health of children. The repercussions of prolonged school closure can be detrimental and possibly even long-lasting. And children of economically disadvantaged backgrounds are disproportionately more affected than affluent children. Thank you very much.
Thank you, Dr. Ahmed. That was a very insightful presentation. And again, thanks for the questions we'll address towards the end. I would like to introduce our last speaker, Dr. Kashif Pirzada. He's the assistant professor at University of Toronto and McMaster University, and he's an emergency physician here in Toronto. Welcome, Dr. Pirzada.
Thank you so much for the introduction. I'm just going to pull up my slides. So I'm going to discuss some systemic changes that we've instituted in Canada to prepare your schools and your school system for the introduction of schools and the opening of schools. I'm an emergency physician in Toronto. I have academic ties, but also I'm co-chair of an advocacy group here called Masks for Canada. And advocacy groups in this country have been very important to get a lot of basic public health measures passed because of lagging government officials. And so we've gotten mask bylaws passed, and we're working on trying to make schools as safe as possible. So key components that we've seen in different programs is that masks need to be required at all grade levels, including kindergarten. Ventilation has to be addressed. This is an oftenly missed point, and very few places are looking at this right now. Class sizes need to remain small and small cohorts as well. There needs to be some program for rapid testing, which I think is ahead in Pakistan versus the West. And there needs to be clear and effective plans to contain outbreaks. Masks can be challenging, especially for younger children. They need training. There needs to be resources for parents to show them how to wear masks and how to properly take them on and off. Children in my region are being asked to bring 5 spare masks to their schools and then to bring a pouch in which to store them throughout the day. They also need to stagger meal times so that not all children have taken their mask off to eat at the same time as well. We have created some resources that you can use, sort of coloring pages, checklists, sort of a checklist that parents can go through. And you can download these at our website, masksforcanada.org. And these are being used in local school boards to help train students. Also additional resources for educators and parents as well. And I left the URL on the slides. Another major issue is addressing ventilation and HVAC. Masks alone will not work. If you're in an enclosed space with poor ventilation, even small aerosols will linger in the atmosphere and potentially infect. Open windows where you can. This is probably better done in southern countries versus the north, where we're already getting an early winter. You need to survey each classroom and measure the airflow characteristics. And this can use expensive equipment, or you can just use a CO2 monitor in a room that's already full. High CO2 levels indicate that there's poor airflow in that room. You need to ensure that there's at least 3 air changes per hour. That's the basic minimum. So that's 3 air changes with fresh air. 6 is best. If you have central heating and air conditioning, you need to install MERV 13 filters. MERV is a classification developed by the ASHRAE, the American Society of Heating and Air Conditioning. If you can ensure a safe space, a portable HEPA filter unit is probably best to use in those cases, if you can get one. This is an outdoor classroom. This is what I saw when I did some refugee work in Azad Kashmir. This was done because the school behind was destroyed, but this is something that you should consider doing more and more. Use unconventional spaces, outdoor spaces, as much as you can while the weather permits. The New York City has been probably the most effective surveyor of ventilation in their schools. They went through, in 1 week, 100 team of engineers went through 1,600 schools and they had to close 10 of those schools and take many classrooms offline. They went classroom by classroom to certify which rooms were safe and how many people can be in those rooms. And they put every result online. So they're an excellent model to follow. You can create, your own filters with furnace filters and box fans. There's a lot of tutorials online, but don't do something like that unless you have clearance from your building authorities. You don't want to create a fire hazard. There's a great resource made by Harvard University School of Public Health, the Schools for Health, Healthy Buildings. The URL is here. There's also another URL created, a document created by engineers to go over the propagation of aerosols as well. This is a great spreadsheet created by the Harvard group. This can help you calculate the flow characteristics in your room, and it help you decide if you need better ventilation in there. And this is the link to the Google Doc directly. The other important issue is small class sizes and cohorts. We've seen, in my colleague's presentation that it doesn't take much to spread. The data is still coming in. This is the world's greatest science experiment going on right now. But limiting the potential impact is probably the best way to go. Keep the cohorts separate from each other. You need to partition play areas. You need to stagger entry and exit times from the schools as well so that cohorts do not interact with each other. Monitor the use of washrooms and look to jurisdictions that have had the best planning so far, which I've seen has been probably Denmark and New York City, which delayed their school opening another week just to make sure everything is right. The worst is Israel, as mentioned by my colleague, and in my country, in Quebec, which basically opened schools with almost no protections at all. So there's some cautionary tales for you. This is a study that was done at our local hospital for sick children, which did an observational study between students in a simulated classroom. And they, again, have a list of recommendations, which you can find at this link, but they include small class sizes, routine screening, and cohorting, and
If we can take some questions
Sure.
meanwhile.
We will wait for Dr. Pirzati to come online. In the meantime, I will start the Q&A.
Yeah.
Are you back, Dr. Pirzati? No, okay. So the first question is for Dr. Arshad. One person is wondering, the fear of nasopharyngeal testing is more scary and is on the rise. Are there any alternatives that are reliable without that kind of swab going up your nose?
Yeah, there have been some studies. I totally agree. I think especially for children, it's actually pretty hard to like hold them down and shove a nasopharynx and the swab up their nose. There are other studies that have looked at saliva tests that are coming out to be more reliable, and also some further studies that used exactly the same swab and same technology, but have looked at anterior nair. So you sort of just look at the front part of the nose and an oropharyngeal swab. So there are, but it's very dependent on what kind of test is available in your local institution and what kind of validations they have done. But across the world, more and more studies, more and more tests are being available that are validated for less problematic sample collection. I think Dr. Kashif is back if you want to.
Yes, go ahead, Dr. Pirzati.
Okay, I'll go where I left off. I'll go back one slide. So prior to opening, you need to present clear plans and procedures. That's been a source of major confusion in our jurisdiction, that there's many different authorities. No one knows what's going on, and communication is not very clear. Just putting tough on a Twitter account is not sufficient. You need to have better lines of communication. Flowcharts are great. Expand local testing. In my jurisdiction, local testing has become overwhelmed because of the prospects of another wave. So this needs to be expanded with rapid tests if you can. If you can validate saliva testing, many jurisdictions have done that already, and it's better tolerated by students. Essential components in an outbreak containment plan includes screening. So whether your parents and students complete screening before coming to class, a QR code, an app, or just paper-based, or if you do a rapid test like a saliva or spit test on a lateral flow assay like a test strip. Setting up isolation rooms for symptomatic students or teachers where they can wait to go home. Have a robust contact tracing and inform the local school community of outbreaks. You need to have returning to school procedures after exposures and after illnesses for students and teachers. And you also need to determine a case threshold for school closure, and also a community prevalence threshold for school closure, which isn't been set in our jurisdiction. There's a lot of confusion. Schools are being closed already, but it's not known where public health would draw that threshold. So it's some information that should be out there. This is a flowchart that we made to help guide in the Toronto area. This is an example that you can use in your jurisdictions as well. What to do if there's a COVID-19 case, and a decision tree that follows after that as well. And it's nicely and clearly communicated here. Systemic fixes that you can tackle before you open schools or during is that ensure that you have good online education options. It's very likely in my jurisdiction that the school year will end very shortly as cases are rising exponentially. Right now, the plan is just to throw all the students back onto the online platform that they were using in the spring. So if you have that ready, that will help you make sure that they have an uninterrupted school year. But as Samia mentioned, there's a lot of systemic issues behind that, unfortunately, that it might not be optimal for everybody. Selective lockdowns, here bars and restaurants are still open, but they probably should close now, and they're not, unfortunately, because of political issues, but that's something to consider. Safe school transport, ensure that public transport is safe, ensure masking is required on your public transport system, and help staff stay at one school at one time. We noticed here in seniors' homes that a lot of spread happened from staff that were circulating between 2 or 3 homes. Same thing with part-time teachers. They should be restricted to one school at one time. This is a table we constructed to compare return to school plans across different provinces in Canada. And so we found that there's insufficiencies pretty much in every province and areas for improvement as well. You can try to use the same criteria and do the same thing with your school systems and see if there's areas that can improve. Nobody's doing this perfectly, which is why I think in my country, school opening is probably going to be a short project. Another important thing is to educate yourself, your colleagues, teachers, physicians to take care of yourself. It's easy to ignore yourself in this hectic and busy time. You need to go in with a prepared mindset, like I think many of us have since March when the pandemic really began. Try to ensure that you stay healthy, do self-care, make sure you stay hydrated and well fed. Try to partition your work and your home equipment and supplies. Ensure that your vehicle is safe and that you're going there in a safe manner. Ensure that you have some personal PPE, including masks and face shields. And engage in stress management if you can. Avail yourself of resources that are available at this time. This is an unprecedented crisis that hopefully will only come, once in our lifetimes, but that's not a guarantee. And everyone is going through the same thing right now. Basic things that we've adopted in the medical setting, which are equally applicable to the school setting, is practice donning and doffing your PPE, which would be your mask and face shield. Don't bring your work clothes, pens, and other supplies at home. I know many schools have gotten paper lists as well. That's another way to limit fomites. Even though there's increasing evidence that fomites aren't the main vector of spread, it's best to be cautious in these cases. I would say wash your hands when you get home, take a shower. Consider your car, the gear shifter, the steering wheel contaminated and clean frequently. Be careful when eating at work, especially since you have to take off your mask. Try to eat before and after, or eat in a private area with good ventilation. And no handshakes. We're in the fist bump or the elbow bump era, or the Vulcan salute. So be careful with that. My colleague has created an excellent presentation with good resources and strategies. And you can access it at this URL. A very worthwhile presentation to go through. Thank you very much. I'm available for questions, and you can follow me on Twitter if you want to see more of my posts on this. Thank you so much.
Thank you, Dr. Pirzada. That was a very insightful presentation. I think we will take some questions now. The next question that has come up is for Dr. Ahmed. What are your thoughts on what should the guideline be for special population in schools, such as children with disability or in the autistic spectrum, and they require more attention and more sort of tools to learn? What can schools do or society do to help them thrive in the school environment?
Yes, thank you so much. That's a very good question. So like I mentioned, children who have special needs, especially like autism spectrum disorder, they will be very significantly and more affected than children who have appropriate development. And many of the reasons for this is that many of the treatments and the improved behavior comes from having structure in their lives. So they need a place to go every day, a routine, and have that every day. Now that's very difficult to recreate at home. So it's much better for children with the right precautions with these disabilities to go to school. And if that's not possible with all the precautions that Dr. Pirzada said, then to try to make those interventions at home. So children like this, they should have all the equipment should be cleaned, occupational therapy, physical therapy, all the supplies that they're using, they should be wiped down, cleaned. If they're working with a provider, don't change the therapist all the time. Have the same person come every day and work with them, the same teacher work with them every day. Both people should be masked if they can tolerate it. Try to do as many of these therapies and sessions that they need outdoors. There are children taking violin lessons outdoors. There are children doing, so really you have to think outside the box. So I think these are the children who definitely really need to go back to their routine, but in a safe manner. So I would support, as many interventions we do. And I think we have to remember to, again, kind of think outside the box. I know if some of them are immunocompromised, they really cannot go to school. So what we do is we do virtual therapy sessions. And in this, the parent or the caregiver needs to be very involved. So they have the therapist online telling them what to do. Move their hand like this, do these many presses with the hand, get them up, stand, bear weight, take a few steps. And there's so many online resources. Parents may have to supplement, or caregivers by themselves look up other therapies that they can do in addition. I hope that answers the question. Thank you.
Perfect. Thank you so much. The next question is for Dr. Mehreen Arshad. If you did get COVID and you have lost the antibodies, so you don't have IgM, IgG antibody anymore, what are your risk of reinfection in the subsequent months?
Yeah, that's a really good question. We, and I will say we have no idea. We actually don't even know the role of positive antibody testing in terms of the protection against the virus. I will say though that many viruses, there are different ways that your body fights viruses. So it's obviously antibodies, production is one way, but there's also something called cellular immunity. So there are T cells and B cells that are primed to attack and to attack the virus, and that is something that we are not able to actually measure using the current assays that we have. So to answer your question, we don't really know what the risk of reinfection is if the antibodies go away. We actually don't even know the risk of reinfection when your antibody test is positive. We presume that within 3 months after the initial infection, your risk of reinfection is very, very low. But to be honest, that's just a presumption.
Okay. The next question is for Dr. Pirzada. In terms of wearing masks, like the kids are required to wear masks for long periods of time when they're, running around in classroom, going up and down, playing. Is there any problems of prolonged mask wearing in terms of oxygen deprivation? What are your thoughts on that?
Not that we know of. As you know, like we wear masks if you're in the OR, 12, 14, 15 hours. I did my medical school during the first SARS outbreak in 2003, and we had to wear an N95 for 16 hours at a time. We weren't allowed to touch it, or we were suspended or thrown out of school. And there's no oxygen deprivation, multiple studies on it. It can be tough just to have something on your face. Best thing is to have, if you're wearing a mask, a triple ply mask, but with a cotton inner layer. Cotton being a natural fabric is a lot easier to wear. But have, several spares, like 5 spares is the recommended right now per day for each student. But again, no evidence of anything to do with oxygen deprivation whatsoever.
Okay, very good. Dr. Ahmed, what are your thoughts on PTSD post-COVID, and how do you see those signs in a young child? Like they won't be able to verbalize what they're feeling. How can parents and caregivers and teachers be on the lookout for that now that they will be seeing them, but they're masked and they're not able to verbalize, or even the facial expressions are hidden?
Yes, that's a very interesting question. So I think if thinking of PTSD, I think we have to go in the spectrum of the mental health illnesses. So whether children will develop an anxiety from this, or will they develop maybe more of like an obsession compulsion from this? So some maybe OCD tendencies coming out. There is such a huge push towards not touching anything and wiping your hands with everything, wiping down all your equipment. Where does this stop? So if you have somebody with maybe some underlying anxiety or with some OCD tendencies, I would worry that this may kind of trigger a potential for developing some OCD tendencies, which can be very troublesome for children and adults alike. In terms of long term, I think maybe the social networks that are broken, children especially who are very shy and quiet, maybe they will feel that, there's a whole world out there that's just online. They may just recede into that and not really care like to go out again and just say, well, we have online friends, we play video games online. And I already have patients in my population that say this, those who already homeschool or choose to do online schooling at despite a pandemic. So we may see things like this come out. And also, what are the negatives of this now? You know, we know concerns for like cyberbullying and obesity and sedentary habits. So I think many of those side effects and things might come out later. So that's very, very interesting. Yes.
Okay, great, thanks. Dr. Arshid, since you mentioned that from 0 to 10, the risk of spreading is less compared to 10 to 19. What are your recommendations, or what do you think the recommendations should be for teaching practices depending on their age, since the spread might be higher in 10 to 19 age group?
Right. No, that's a really good question, and I think because of the data that I mentioned, a lot of the school districts are in the U.S. and also around the world are doing staggered opening. So they're actually opening the younger age group, so elementary school first, trying to see how that goes. And in our school district, for example, the high school is closed. They have said no matter what the rates of COVID-19 in our district are, the high school for this year is going to be virtual. And there are multiple reasons for that. It's it's obviously the viral transmission that I showed, but also the younger age group needs, as Dr. Ahmed mentioned, needs more supervision. They need more, that's where the foundation of education is being laid. And so I think it's school districts that have done this strategy, I think have actually done a lot better. And kids who are younger need more supervision. So if their parents have to go to work, the older age group tends to do better. Virtually, they're a little bit more tech savvy these days as well, and they perhaps need a little bit less supervision at home as well. So I think any strategy that involves opening elementary schools first, especially when rates of transmission in the community are reasonably high, I think is a better strategy than opening everything together, all age groups at the same time.
Great, thank you. The next question is for Dr. Pirzada. You mentioned open air classrooms are quite, the ventilation definitely is much better than indoors. What are your thoughts on evening classes? Maybe they can, some groups can go to school in the morning, some in the evening and outdoors. And also with the winter coming up, if you were to envision a school or, have a role in opening a school, how would you plan it out?
So I think it depends on what region you're in. So a winter in Karachi versus a winter in, the northern areas, winter in Toronto, which is, inhospitable to life of any sort, is different. I would plan it out by using every community space possible. So approach, local institutions like community centers, libraries, malls, try to spread out as much as possible. Try to, keep your cohorts, but like I said, mentioned to assess the ventilation where you can. Use outdoor spaces while you can, and if you can do it safely. I think at evening, it might be inconvenient for families to convene schools, but it might be good for older students and teenagers. But yeah, use whatever you can. This is a time to be creative and to find unconventional places to do things.
Perfect, thank you. Dr. Ahmed, you do see a lot of kids, and then some kids might be asymptomatic. So one parent is asking, if my kid is asymptomatic, should the parents be screened in case the parents have, contracted the virus from the kids? Is there any guideline regarding that, or what are your thoughts of if the child is asymptomatic, but the parent is wondering that since their rate of transmission is higher, should they be screened? What are your thoughts?
I can answer that. So we do recommend when we see a positive child, especially if they're asymptomatic, we do recommend that the family members also get tested. Especially so sort of the data is changing right now, but earlier on in the pandemic, when we saw a positive patient, we knew that 90% of the time they were actually getting it from their from their family members. And so, it is very important that any household member, even if there are other siblings, should get tested and not just, not just rely on symptoms alone. And you're right, there are, even in adults, there is some data that shows that 30 to 40% of the adults are asymptomatic carriers, or don't actually get too many symptoms. So test-based strategies are, I think, crucial to containing the viral.
Okay, so there's a follow-up question. Most kids will be complaining of a tummy ache, and maybe the child doesn't want to go to school, or it is genuinely a tummy ache, and COVID presents in many different ways. So how can you differentiate between a tummy ache being just a stomach bug compared to that being a presentation of COVID? Are there any other signs and symptoms that the parents should be looking out for?
Yeah, this is a very difficult question, and I think something that we have struggled in across the world, really, because in children, the presentation of COVID is very similar to all the other infections that we very typically see in this age group. So it is a very, very difficult question to answer. In terms of specifically, stomach aches and GI symptoms, they do happen in children. They can be a presentation of COVID-19, but they usually happen along with other symptoms as well. So, respiratory symptoms of fever. Standalone, like just stomach ache without anything else, is not that likely to be COVID. But if there's either a positive contact, or if if there's a fever associated with it, or if there are other respiratory symptoms or fatigue or anything else, I think there you have to treat it as presumed COVID-19 and get tested. I think these are the situations which, as Dr. Prizarda mentioned, that more sort of rapid testing, pooled testing, these are the kind of situations where that sort of strategy is helpful, because if we are going to open schools safely, we need a lot of testing, a lot more than what we're doing right now. And the reason for that is, as we go into the winter season, we're going to see more and more of the other non-COVID viral illnesses, but we're not able to distinguish between the COVID-19 and other viral illnesses. And so just testing and retesting and is absolutely crucial.
Yeah, and also as a gastroenterologist, I see this in adults all the time. The other thing is definitely know your child. If it is not right, if he or she is behaving a bit differently, get tested. I know it's not the best thing that parents want to do, but the idea is to be on the safe side these days. We'll just wrap up in a couple of questions. The next question is for Dr. Pirzada. There has been so many changes in guidelines. What do you think in terms of infection control is the best practice? Because as the COVID has been evolving in the last 6 months, first they said no mask, now there is mask that's mandatory. What do you think is the best practice in terms of infection control in schools?
In schools, I think the best practice is every living creature inside the school should be wearing a mask, and it should be a multiple ply mask. It's the only way. Source control is the way to go. It's unfeasible for everyone to be wearing N95s if you're trying to control the aerosol aspect of spread. So everyone should be wearing a multi-ply mask on their face, control any aerosols, look at the ventilation. Those are the basics that will spread, that will stop 99% of spread. Distancing as well, and hand washing regularly are important. But overall, have a plan to shut down quickly if things get out of control in your region. And that's where we're headed right now, and where I am right now. And I think it's a question of sooner rather than later. So just have that plan ready in place as well.
Okay, great. Dr. Arshad, when one parent is asking that, is the risk of contracting COVID from an asymptomatic child the same as from a severely ill child?
Probably not. Again, we don't really have very clear data on that, but I guess I should say we don't really know, because we do know that some asymptomatic children have very high viral loads, but we really don't know what the risk is of transmission from asymptomatic children in in adults, we do know that those who are asymptomatic, sometimes they do tend to have lower viral loads, and so the risk of transmission is also lower. But in children, the asymptomatic children seem to have almost the same amounts of virus in their body than those that are severely infected. So we're not really sure. We do think that younger children, again, I think it's more age dependent rather than symptom dependent. And again, I think it sort of comes back to younger children tend to be able to, they probably aerosolize less, they probably transmit less just because of their the mechanics of their respiratory symptom. So that's sort of what I would say, rather than basing this on, rather than basing the risk of transmission on the symptoms of the child.
Okay. So this question is for all the panelists. So supplements, multivitamins, herbs, all taken in prophylaxis. Is there any evidence for that? And what do you think if people take it in excess? Is there any danger to that?
Yeah, so I can take this first. There is no data. People have been trying to look at, vitamin C, zinc is the other thing, vitamin D. But if you look at the actual data, there are some, I guess, some theoretical benefits where some of these are antioxidants. They may have some role in, some antiviral properties. But vitamin C, for example, has been, that's one vitamin that has been studied in the context of ICUs and sepsis. But it's very, very high levels of vitamin C. So I read somewhere it's basically the same. The vitamin C dose that they use in sepsis protocols in the US in some institutions, for example, is equivalent to eating 100 oranges at the same time. So it's like 100 oranges, which is like absolutely impossible, right? So it's not, there really isn't a whole lot of data, and there are some side effects of some of these some of the supplements, so especially like the fat soluble vitamins such as vitamin D, they can stick around your body for a long time. So if you have very high amounts of it, thinking that it's going to help, you can actually get toxicity from that. And like that, there's some other herbal herbs as well. So I would say that vitamin supplements are fine, but do not go overboard. There really isn't much data to sort of support that they are protective. And the other thing I think also is it also gives you a false sense of security. So don't think just because you're having vitamin C or vitamin D that you're not going to get COVID. You do need to take all the other precautions that we've talked about during this talk.
Perfect. Go ahead, Dr.
Yeah, so I would, yes, it's a very interesting question because I think many people are taking some supplements, and I think I would agree with what Dr. Arshad said, is not to get a false sense of security, but also keep each child and member of the family in mind as to what their needs are. So if you have a picky eater, either just by behavior or because of some underlying problems they may have with swallowing or dentition, then they may need vitamin supplements. Same thing if they are taking medications that would deplete some of these vitamins or essential minerals, such as like I give patients, steroids for demyelinating disease or phenobarbital. These will decrease, bone density. So those children will need vitamin D, calcium, or if somebody has renal problems. So I would take each child and see what their needs are, and not do something in excess, and maybe also talk with your doctor about what their needs are. Thank you.
Perfect. Dr. Ahmed, what do you, like one of your slides mentioned that closing schools can even have effect 10, 40 years from the get-go. What can parents do if they have chosen to homeschool or virtually teach their children to mitigate that effect in the long term? You're muted.
Yeah, I'm trying to, there, yes, I'm unmuted, thank you. Yes, absolutely. So that's a very good question because there's a lot that parents can do at home. So parents can actually be the best teachers if they are motivated enough, if they have the resources, their own education. So such as if you have a kindergartner or first grader, you need to maybe get in touch with some online program or some curriculum, or even just speak with your school. Can you send me the curriculum and I can do it myself? So, basics of mathematics, reading, don't let this year slip by and that they do not use that foundation, because what happens is that that same child, if they carry that deficit, they will miss what they were supposed to learn in second grade. Then they will miss what they were supposed to learn in third grade. So that's when they talk about, like, when they graduate high school, maybe they're still not even reading properly. They cannot even get a professional job compared to somebody who was in school and went through all the education. Maybe they don't know how to manage their money because their mathematics skills are poor. And so it's just a downhill from there. If you don't have that base foundation, you can't build the staircase. Okay, so parents can do a lot at home by teaching.
Perfect. I think we'll just go for the last question and then end the session. Dr. Pirzada, what has the ER burden been for you? How are the trends in your ER shifts, and any interesting case that you can recall?
The burden is increasing a lot in the last week or so in my region. I think we're full of what we call PUIs, people under investigation. And the ICU numbers are going up as well. In my hospital, we've had a doubling of our ICU load from COVID, and we haven't emptied it out like we did the last time when we stopped elective surgeries. So I think it's headed in a negative direction for now. There's a lot of public health education on trying to get people. Most of the spread is happening in people below age 40, and there's a lot of public health pitches to try to get them to stop. But, we had a great summer, though. Almost no cases at all in the summer. And sadly, we wasted that time. And so, I'm not looking forward to the winter, that's for sure.
Okay, one last question for Dr. Arshad. So if the child has symptoms and has gone for testing, until the test results are back in, say, 48 hours or what have you, since we don't have the rapid test, should the entire family, including the child, quarantine for 14 days or start to do that? And then if it's negative, then stop right away? Or because it's a big confusion among parents, what should they be doing during that time?
Yeah, that's a good question. So yes, absolutely. If somebody is tested and you're waiting for the result, everybody needs to be needs to quarantine. The entire family needs to quarantine, because what happens and the duration of quarantine and isolation for that family or for the child depends on that particular test. We have had families in the US send their child to school while the test is pending, and then that child becomes a source of infection for multiple other people within. So yes, absolutely. If there is a test pending, should be a no-brainer to keep the child at home, to make sure that the family is quarantined. If there is, and then it really depends, there is some thought that there is a high rate of false negativity in the test as well, so that in other words, the test is not very reliable. I think the way that we've approached that in the US in my school district is that if you have a known COVID test, or a known COVID contact, so for example, you have there is a classroom where one child was tested positive and the other children are now being tested or quarantined. I think in that case, you have to do at least 10 days of isolation, or 10 to 14 days, ideally 14 days of isolation, because you can get infected or you can show symptoms at any time during that period. If a test is being done because the child or the adult already has symptoms, theoretically the risk of false negative should be much lower. So I think that's how we've approached it. So if you are in contact with a positive case, make sure that you quarantine for the full duration, 10 to 14 days, ideally 14 days. But if you are being tested because you yourself have symptoms and the test is negative, then I think that test is a little bit more reliable.
Okay, perfect. Thank you so much to our expert panelists. It was a great presentation from all of you. And again, I would like to thank GetSparba and obviously Humanity Auxilium for letting us give this opportunity to present. And hopefully we'll have some more sessions in the future and similar topics, and we can go from there. Thank you so much for joining us today, everybody.